You know, in the high-stakes world of the intensive care unit, doctors use some incredibly powerful tools to save lives. But what if one of the most common tools, a drug that helps patients breathe, is actually a double-edged sword? What if it has a hidden, long-term cost? Well, that's exactly what we're going to unpack. So here's the big question we're tackling today. Can a medication that is absolutely essential for helping someone survive a critical illness also, paradoxically, cause lasting muscle weakness? We're going to dig into a major scientific review to see if this is true. Okay, so the drugs at the center of this whole thing are called neuromuscular blocking agents, or NMBAs. The easiest way to think about them is like a temporary off switch for the body's muscles. Now, this is super important for patients with really severe lung injuries because it lets a machine, a ventilator, do all the breathing for them without their body fighting it. It's a life-saving move. But at what cost? To answer that, we're diving into a huge meta-analysis. That's a study that pulls together the data from a bunch of other studies. And, at first glance, the answer looks pretty straightforward.
And we're not talking about a small sample here. The scale of the evidence is really impressive. Researchers combined 19 different studies, looking at data from over 2,000 critically ill patients. So that gives us our first big clue about this potential link.
So when you pool all that data together, something definitely jumps out. About 51% of the patients who got these NMBA drugs ended up with muscle dysfunction. Compare that to only 39% in the group that didn't get the drugs. On paper, that's a statistically significant difference. The study's authors really summed it up perfectly. They said it suggests a modest association. So, case closed, right? The drugs increase the risk. Well, as it so often goes in science, the real story is way more complicated than that. And this is exactly where the picture starts to get a little fuzzy. To really get what's going on, we have to look past that simple headline number. This is the critical question any good researcher has to ask. I mean, are all studies really created equal? Some are just designed better, with less room for error. So what happens when we strip away the noise and just focus on the most reliable, highest quality evidence? And boom, the story completely flips on its head. On the left, you see our original finding, that modest but significant link. But look at the right. When the researchers isolated only the best, highest quality studies, that link just disappeared. The numbers were kind of similar, yeah, but the margin of error was so wide that you couldn't say for sure it wasn't just random chance. So what gives? Why the big difference? Well, the answer comes down to something called confounding factors. These are all the other things that could be causing the muscle weakness and just muddying up the data. For instance, were the patients getting NMBAs just sicker to begin with? Were they also getting high doses of steroids, which we know can affect muscles? Or maybe a nasty infection like sepsis was the real bad guy here. And that, right there, is the key. The highest quality studies were able to control for all those confounders. They could actually isolate the effect of the NMBA drug all by itself. And when they did that, the link to muscle weakness in the average ICU patient, it just faded away. But wait, the story is not over, not even close. Because average results can be really deceiving. They can hide extreme risks for very specific groups of people. And this is where the research uncovers something absolutely vital for doctors making decisions at the bedside. So let's be super clear on this. Based on the best evidence we have, for the majority of patients in the ICU, the risk of getting muscle weakness just from NMBAs seems to be pretty small, and maybe not even statistically real. And that's actually reassuring. But the researchers drilled down and they found one specific subgroup of patients where the risk wasn't small at all. In fact, for them, it was huge. 5.36. This number is something called an odds ratio. Basically, a score of 1 means no link at all. Anything higher means there's a risk. And this massive number, 5.36, it's tied to one very specific group, patients with severe sepsis. And this, my friends, is the absolute heart of the matter. For a patient who is already fighting a massive infection, like severe sepsis, adding an NMBA drug to the mix multiplies their odds of developing long-term muscle weakness by more than 5 times. This is that hidden danger the initial data completely missed. It's not about the drug alone. It's about how the drug interacts with the specific, really vulnerable patient. So this all leads us to the real-world problem, right? How does a doctor in the middle of a crisis use this kind of complex, nuanced information to make the best call for the patient right there in front of them? All right, so let's pull this all together. What have we learned? First, the link between these drugs and muscle weakness isn't a sure thing for everyone. For most patients, the risk is probably small. But, and this is a huge but, for patients with severe sepsis, that risk is substantial and very, very real. It just proves that in medicine, context is absolutely everything. Okay, so what does this actually mean for doctors working in the ICU? Well, the guidance is pretty clear. You've got to be extremely cautious using these drugs in patients with severe sepsis. If you absolutely have to use them, the goal is the shortest time possible, ideally less than 48 hours. It's always a balancing act, weighing the life-saving benefits against these very real patient-specific risks. And that really leaves us with a final, tough question, doesn't it? This whole explainer just goes to show that modern medicine is rarely about simple yes or no answers. It's all about navigating uncertainty, about understanding who is most at risk, and constantly weighing potential benefits against potential harms. Making the best choice, well, that takes more than just data. It takes wisdom.